Good morning, everyone, and happy holidays. My name is Adam Del Molino, and I am the Senior Director of Virtual Care and Clinical Affairs here at the Massachusetts Health and Hospital Association. I want to welcome you to today's webinar, Turning to 2024, a landmark year for digital health innovation. A few logistics before we start. If you have questions during the webinar, please enter them into the chat feature as we are in listen-only mode. The questions will come directly to us, and we will do our best to address as many as we can at the end of this presentation. I also want to take a moment now to thank MHA's 2023 sponsors for their support in underwriting today's webinar, which is just one of many events we offer throughout the year to connect our members with leading experts on the timely issues that we're discussing today. I'm pleased to introduce our presenters for today's webinar, Amy Joseph and Jeremy Scherer from Hooper Lundy and Bookman. Amy Joseph is a partner at Hooper Lundy Bookman and co-chair of the Academic Medical Center Teaching Hospital Working Group. She is a trusted advisor and respected thought leader on healthcare issues. Amy counsels health systems, academic medical centers, teaching hospitals, and other providers on a broad spectrum of regulatory and business matters. Amy does significant work on patient privacy matters, including HIPAA, the confidentiality of substance use disorder patient records, and state law compliance on behalf of all types of providers. She frequently counsels both providers and health information technology companies in the digital health space, including addressing compliance and reimbursement issues. Amy also leverages her extensive regulatory experience in transactional matters, serving as lead deal counsel or regulatory counsel on mergers, acquisitions, and other strategic affiliations. Jeremy Scherer is a partner at Hooper Lundy and Bookman and also the co-chair of their digital health practice. Widely recognized as a digital health thought leader, Jeremy counsels healthcare providers and suppliers, including hospital systems, national telehealth platforms, investors, and digital health startups on issues involving regulatory compliance, transactions, and innovative business arrangements. Jeremy's telehealth experience includes compliance with state licensure requirements for physicians and non-physician practitioners, corporate practice of medicine issues, remote prescribing, including controlled substances, patient consent, and Medicare, Medicaid, and commercial telehealth reimbursement. He also regularly advises clients on compliance with fraud and abuse laws, including federal and state anti-kickback rules and self-referral laws, in addition to privacy issues arising under HIPAA and its state-level counterparts. Thank you all for being here today. Jeremy, I'd like to hand the presentation over to you.
Thanks, Adam. Let's collectively make a note before the next one of these that Amy and I need to get you shorter bios for ourselves. That was greatly appreciated, but a lot. Okay. Are we good? Am I screen sharing? Can
you are.
See my lunch order or anything up there? No, all set?
Nope, you're good.
Okay, cool. Hi, everybody. Thanks for joining. I won't do any more introduction after everything that Adam just said, which was greatly appreciated. Today, what we're going to be talking about is what lies ahead in 2024, which, it seems at the end of every year we say, next year is going to be the big one. Next year is really going to matter. When it comes to telehealth, I think that's actually the case this year. I've heard it being called the Super Bowl of digital health, which I actually think is the wrong term because the Super Bowl happens every year. And this is the Olympics, is the World Cup, I don't know, but maybe it's a Y2K event. But this is something that hasn't happened in terms of the alignment of different issues at the federal level that, as it currently stands, are expected to be resolved in the next 12 months. And the reason why it's important to be aware of that is, this is really the time for folks for whom telehealth and digital health more broadly are areas of priority and emphasis, where it's really important for your practice, for your facility, for whatever it is you're doing. This is the year to make it count, and this is not just a plug for MHA, but to be engaged with other organizations as well, to be pulling in favors, to be sending letters to your elected representatives in Washington. This is the year that we expect material decisions to be made with regard to the future of telehealth in particular, and the Medicare program. As well as at the federal level across the board, where they have jurisdiction with regard to controlled substances issues. So in terms of what we're going to talk about, the first section, Amy and I will split, is talking about the Medicare Physician Fee Schedule final rule, which is, of course, the process that CMS goes through on an annual basis to announce what changes it is making to the coverage and reimbursement of services that are furnished to Medicare beneficiaries. And here we'll have particular emphasis on telehealth provisions, but also healthcare innovation more broadly. Then we'll talk about sort of going through 2023, which was a year with a lot of action with regard to federal rules involving prescribing controlled substances virtually under the Controlled Substances Act as amended by the Ryan-Haight Act. Then Amy will briefly talk through the changes that we've seen here that are underway with regard to the Division of Insurance, the DOI in Massachusetts. Anybody who is active with the telehealth work group through MHA is familiar with that issue. But we thought, in talking about sort of what's on the horizon for 2024, it wouldn't be complete in Massachusetts without that discussion. And then we will very quickly touch on a number of other issues which could appropriately warrant their own separate presentations, but we'll just quickly sort of touch on them, including the role of AI, artificial intelligence, in the provision of healthcare services and interstate licensure. So with that, I will go into the Medicare Physician Fee Schedule final rule for calendar year 2024. In terms of telehealth and what is relevant in the 2024 final rule, we'll first want to talk about how we got here, what has happened in the past 3.5 years during the pandemic with regard to telehealth services in the Medicare program, what developments we see in this final rule that are going to be impactful for providers in 2024 and beyond, and then talking about sort of where this leaves us in sort of the big picture sense. In terms of how we got here, during the COVID-19 pandemic, we saw and forgive me, folks, for whom this is review, but we thought it'd be important to quickly sort of set the table. We experienced a complete paradigm shift with regard to the coverage and reimbursement of telehealth services furnished to Medicare beneficiaries, which are known as the defined term as Medicare telehealth services. And the reason why that defined term matters is because once something is a Medicare telehealth service under the Social Security Act, which is a statute and therefore can only be amended by Congress, a Medicare telehealth service has to meet a number of coverage and reimbursement requirements. Again, those are statutory. They have been in place for decades. And this is where we've had frustration historically in terms of where the real pressure points have been for healthcare delivery, and in particular those who are interested in utilizing digital health technology to treat Medicare beneficiaries. You have the originating site restriction, which is the rule that has required, which is prohibited patients from obtaining care while they're located in the home, which sort of negates the miracle of telehealth and being able to meet patients where they are, and also requires them to be in a brick and mortar healthcare facility, whether it's a hospital facility, a skilled nursing facility, an outpatient practice. That's the originating site rule. And then the related second one everyone's familiar with is the rural health professional shortage area requirement, where Pre-pandemic, folks could only obtain treatment via telehealth as Medicare beneficiaries if they were in addition to needing to be in an approved originating site facility, they needed to either be in effectively a medically underserved rural area or certain other types of medically underserved areas. The care had to be provided through what was called an interactive audio video technology system, which is sort of a fancy way of saying synchronous audio video technology, or Skype, Zoom, FaceTime. We saw the list of Medicare telehealth services, that the list of services that could be provided via telehealth drastically expanded during the pandemic. We saw the originating site restriction go away. We saw the rural HIPAA requirement go away. We saw the interactive audio video technology requirement go away. And we saw the widespread coverage of audio only services. And then the last one is the expanded practitioner list, where again, in addition to all the other requirements that we've talked about, to obtain treatment via telehealth as a Medicare beneficiary and have that be covered and paid for, there was a list of types of practitioners who were approved to build Medicare program. And critically, that did not include folks like physical therapists, occupational therapists, speech and language pathologists, and others. And so what we saw during the pandemic, and to see a lot of, particularly telehealth advocates, we complain about CMS a lot. This is an instance where the agency was actually quite responsive, quite engaged, and obviously under authority granted by Congress, acted pretty quickly in March 2020 to recognizing that we were in a position where we needed folks to effectively shelter in place, to waive these requirements and get rid of them. And they did not do so in a way where they said these will be waived until X date and then reintroduced, because they had no idea how long the pandemic was going to last. So they said that they were going to be effectively waived until further notice. In the process, you had sort of the floodgates opened, and you had Medicare beneficiaries obtaining all sorts of treatment via telehealth, and they really liked it. It's very popular. Telehealth can do a lot when it comes to expanding access to care. We know that that care can be delivered in a high quality and cost-effective way via telehealth. And so that wasn't a surprise to telehealth advocates. And now the challenge became, as the pandemic went on, and we were in less and less of a scenario where folks had to sort of shelter in place, what do we do about this now? Because folks were relying upon these waivers to deliver care to their patients. And I know that applies to all, if not most, who are on this call. So in 2022, under the Consolidated Appropriations Act, these waivers were extended. They were further extended via the Consolidated Appropriations Act of 2023. And then in the Physician Fee Schedule final rule, CMS confirmed that these waivers would remain in place until the end of calendar year 2024, which aligns with the Consolidated Appropriations Act of 2023. And so what that means is that for all of these waivers that I just discussed, that were introduced early in the pandemic, that have been in place, that we've relied upon, unless there is an act of Congress, unless there's an act of Congress, or it is decided that we can further kick the can down the road and that we need more time in order for Congress to make a decision as to what it's going to do in this area, that those waivers are going to go away. And that will obviously, if that is to happen, that will obviously cause real problems for providers and for patients, of course. In terms of what we saw, other than the sort of clear framing of that telehealth cliff in the 2024 Physician Fee Schedule final rule, there are new services that are covered, including virtual health coaching, which is significant in that health coaching has been a really popular trend in telehealth for the past 5-6 years. And it's really effective. I mean, it's popular because it works. But because of the Medicare telehealth services restrictions that we've been talking about, and sort of Medicare being slower to the telehealth game, as it were, that is an advance in care delivery that had not been afforded to beneficiaries of the Medicare program. The other thing that we identified here is the social determinants of health, SDOH risk assessments, which Amy will talk about a little bit later. In terms of practitioners who can provide care via telehealth, marriage and family therapists and mental health counselors who were made approved billers during the pandemic will remain as such. Anybody who works in the behavioral health space, particularly where there's an interstate practice, knows that we've run into issues because states call practitioners with very similar, if not identical, scopes of practice different things in different situations, not just talking about whether in state A someone is a licensed general social worker or in state B they're a licensed clinical social worker, but also across disciplines that as a matter of state law don't exist in certain places. In Massachusetts, we have licensed mental health counselors. That's not a designation that exists in all states. In California, you have marriage and family therapists. Those don't exist in all states. And so this is something that the Medicare program had to take a look at, and the general trends now from the Biden administration on down. I think the pandemic has made us as a country aware of the behavioral health provider shortage and crisis that we're enduring right now. And so this is consistent with other steps to expand access to behavioral health care. Final point there is that we have the public health emergency flexibilities extended through the end of calendar year 2024. It would be quite something if we were on a webinar 12 days before New Year's, and I said, you're not going to be able to provide these services next year. So we do have another 12 months, but that doesn't mean that there isn't urgency here, because 12 months does go quite quickly. Other things that I want to go through pretty quickly, the physician home address issue. This is one that MHA covered pretty extensively. At the Federal Hospital Association, FAH, covered it quite extensively. And during the pandemic, we, of course, again, needed folks to shelter in place. And so a lot of providers who were normally going into the office to provide care were also staying home, because they didn't want to unnecessarily expose themselves to risk. And they were allowed to provide that care from home to Medicare beneficiaries. The normal process to enroll a site, a location, to be accepted as a place from which providers can furnish care and deliver it to Medicare beneficiaries is that there's paperwork, and you have to register that location, and that registration process is effectively publicly available. It is something that can be made available to members of the general public. And so once we started having providers home, the provider's home be a location from which a lot of providers were providing care, folks sort of took a step back and said, wait a second, so does this mean that we're going to have to make our home addresses publicly available to any patient who wants to know where we live? And we got kind of nervous because CMS waited until quite late in 2023 to provide clarity on this. But they, like all of the other issues that we talked about, they kicked the can, they punted. End of calendar year 2024 is when we will figure this out. For now, that requirement does not apply to folks who are providing care from their homes via telehealth. In terms of reimbursement of Medicare telehealth services, there was during the pandemic, providers were instructed to bill the services the same way as they would have if they were providing care in person. So wherever they were providing care from, at home or elsewhere, if it would have been an outpatient visit otherwise, they would bill it as an outpatient visit. And we weren't sure where Medicare was going to land on that. Fortunately, in the 2024 final rule, we now have clarity that services that are provided on an outpatient basis can be billed at the non-facility rate rather than the facility rate for those services. During the pandemic, CMS had to create a really wonky, the Medicare telehealth services process is wonky and complicated to begin with, where you look at category 1 services, which are similar to services that are already provided or already covered when provided in person by the Medicare program, or category 2 services, which are different, and they have different processes for looking at them. During the pandemic, it got even worse, and we had a third category of services that were going to be added for a temporary basis for the duration of the pandemic. Not that any of us knew when that was going to end, but they would be added for that a temporary duration, but not permanently. CMS has now said they are removing that third level of complexity and going back to the prior effectively two-category system going forward. And from that, I will pass it over to Amy to finish up on the final rule.
Okay, thanks, Jeremy. Yeah, so as Jeremy mentioned, we're going to pivot a little bit and talk a little more broadly about innovation that we see in the final rule. And these are really some services that we now have reimbursement for that are intended to address health-related social needs. So CMS has added codes for services that seek to better value the additional time and effort that practitioners take, whether it's helping a patient navigate the healthcare system or to remove health-related social barriers that are interfering with a patient's ability to adhere to their patient care plan. So we have a quote here on the side of the slide, which you can read. This is from the rule, and it really shows the spirit of what CMS is trying to do. So it is recognizing that medical practice is evolving, and it sees these codes as really getting at equity and inclusion and access to care. So it's very exciting development to see. You might be asking, okay, so what does this have to do with digital health innovation? Because I signed up for a webinar that's all about landmark digital health in 2024. There are two reasons. So first, these are other services which are really moving beyond that old historical in-person, face-to-face, sit down with your practitioner in the office type of service. It's a more holistic service that shows that CMS is embracing this idea of medical care evolving. But second, with these services that we're going to go through, they might be in person, they could be by video visit, they could be by phone call. There's flexibility for how they are delivered. So in that case, there can be a digital health component to the provision of these services. One of them is on the Medicare telehealth services list, as Jeremy mentioned. The other two are not, because Medicare telehealth services, as Jeremy said, is wonky. It's not really what I think of as telehealth. It's its own special definition. So some of these services fall within that and some don't. So we can go to the next slide. Jeremy's helping me by driving today. Okay, so here are the first two services which I wanted to flag for you all: Community Health Integration, or CHI services, and Principal Illness Navigation, or PIN services. So first, let's talk about the CHI services. So what these are really intended to get the types of services that traditionally community health workers would provide, although it could be others that are providing these as well under the supervision of the billing practitioner. And they're really aimed at connecting a patient with resources to help address social determinants of health needs that are really impacting the ability for a provider to diagnose or treat for patient care. And this is looking at things like food insecurity, housing insecurity, difficulty maintaining utilities. There are a lot of requirements around these and the others, which we're just don't have time to get into. And frankly, I don't have them all memorized yet. You know, the frequency of billing, the type of visit that has to happen first. But I thought it was important to share the spirit of these. So I'm going to give an example that CMS provides, which I think is a good way to think about how this type of service can be used. So the example they provide is, let's say you have a primary care physician. They might order these services if they have a patient who's experiencing homelessness and they keep ending up in the ED. And they keep doing that because they have uncontrolled diabetes. And the physician learned that's because this patient keeps losing their medication. They don't have a single secure spot to keep it because they have to keep bouncing around between shelters. So they could order this service for a community health worker to really work with that patient to help communicate between the shelters, find a safe spot to keep the medication, work with the patient to help apply for local housing assistance, addressing all those health-related social needs so that this patient has better reliable access, and that will help keep them out of the ED. Now, Principal Illness Navigation services are a little different. They focus on social aspects of care management for patients with serious high-risk illnesses. Those individuals may or may not also have social determinants of health needs. And what this is getting at is really helping patients navigate the healthcare system when they have a lot to manage given their situation. This could be referrals to supportive services, providing information around clinical trials. It could be meeting with a certified peer support specialist. Similar in some ways to CHI services, that we're seeing a more kind of holistic help to a patient to help them, better access and comply with their care plan. These services are not on the Medicare telehealth services list, but they can be provided in various ways, including virtual. I think we can go to the next slide. Yeah, and this is the last one that Jeremy already touched on briefly. We do have a new reimbursable service for a social determinants of health risk assessment. This has to be connected with a larger E&M visit. And the idea is that a practitioner can use this to really assess and identify if there are unmet needs. And this can be done once every 6 months where it's reasonable and necessary. I have an example as well for how this could be used in practice, because again, for me, kind of conceptualizing how it works in practice really helps me understand how this can move the ball forward. So the example that CMS gives for this is you could have a practitioner who conducts this assessment and they determine that a patient with diabetes does not have reliable access to electricity. And that means they're not able to keep their insulin refrigerated. And you can see, the detriment to patient care, which happens as a result. So as a result of this assessment, the practitioner can then prescribe insulin that doesn't need to be refrigerated. And that allows them to provide a care plan that the patient can actually stick to and attain the goals. So a lot generally throughout the physician fee schedule and social determinants of health, really exciting to see things like this happen. And this is on the Medicare telehealth services list. And yep.
Federal remote prescribing regulations, everyone's favorite topic. Particularly for telehealth advocates, everybody is really sick of this issue, and understandably so, because it should have been resolved a long time ago. It hasn't been. During 2020, during the pandemic, we saw a tremendous amount of change in this area. But to go all the way back in 2008, 2009, for those who aren't sort of living and breathing this area, Congress amended the Controlled Substances Act through the Ryan-Haight Act, which was named after an 18-year-old who overdosed on Vicodin that was prescribed by an online pill mill from a doctor he'd never met, to require an in-person examination before prescribing scheduled controlled medication to patients. There are a number of exceptions that were included at the time. They are mostly heavily rooted in sort of the brick and mortar context, requiring one, if not both, of the parties, the patient and the practitioner, to be located in a brick and mortar healthcare facility. And they really haven't kept pace with the way that telehealth is utilized to deliver care. At the time, in 2008, 2009, Congress called upon the DEA being the federal agency, federal agency which owns the Controlled Substances Act, to create a special telemedicine registration. If folks remember the X waiver for buprenorphine, it was envisioned as, I understand, something similar to that, where a provider could show that they could be trusted to prescribe these very, very powerful and therefore important, but also potentially dangerous and drugs that are subject to diversion, which of course is the DEA's top concern, to show that they can be trusted, and then to be able to prescribe. And they were supposed to outline a process for that. They never did. And despite heavy advocacy by industry for a decade plus, President Trump, in the Support Act of 2018, called upon the DEA to create this process. They never did. Then we have March 2020, pandemic happens. Everybody needs to be sheltering in place because we're dealing with a global pandemic. So the DEA says, okay, we get it. No more in-person requirement. And they also, and we're doing it temporarily. Again, we can't tell you how long this is going to be the case, because no one knows how long the public health emergency is going to last. But in addition to waiving the in-person prescribing requirement, the other requirement of the Controlled Substances Act that is so difficult for providers leveraging digital health technology and providing care across state lines to meet is this requirement where, in addition to being registered, in addition to being licensed to practice medicine, a provider who is prescribing controlled medication to a patient needs to have a DEA registration in every state where a patient is located. Some states, like Massachusetts, have yet another registration requirement. Massachusetts is Controlled Substances Registration is what it's called. And so those registrations also make it really difficult, because in terms of the DEA registrations, they generally need to be tied to sorry if that sound is bleeding through. It sounds like there's a drag race going on outside our office in Boston. Lost my train of thought there. To the extent that they are providing services across multiple states, there needs to be that registration needs to be tied to a brick and mortar address. And if I'm a provider sitting in Massachusetts and I'm a behavioral health specialist licensed in 7 other states, I may not have a physical presence in all of those other states. And so this is an area that's been really difficult for providers to comply with over time, and made it so that pre-pandemic, it was really, for the most part, it was sort of a red line you didn't cross. That in telehealth, outside of the health system context and sort of the brick and mortar world, where you could satisfy a lot of those exceptions by having, for instance, the patient and the provider being located at separate DEA registered hospital facilities, for instance. In the sort of previously direct to consumer world, now maybe the click and mortar realm, as some call it, it was kind of a red line you didn't cross because of this federal law. That went away at the beginning of the pandemic, and as a result, we sort of removed this federal floor, and what we saw underneath were all of these state laws, which also address controlled substances prescribing, which we never really had to bother with before because you had this federal floor. And if you can, I mean, they did their best to make to create this flow chart to make this waiver simple. It was not simple. There's massive confusion, in part because this, I mean, just from a federalism perspective, this is an area where you have conflict between federal and state laws. And so during the pandemic, the bottom line is you had waivers implemented, which resulted in a huge influx in the volume of care that was furnished via telehealth. And then in 2023, DEA finally released proposed rules that it was raising for notice and comment rulemaking, expedited notice and comment rulemaking, I should say. They provided less time than usual, but they provided a couple of new pathways for virtual prescribing, but perhaps most importantly, they didn't include anything about a registration process, that special telemedicine registration that I was referencing. And they sort of stated in a conclusory fashion, without any support, that somehow by creating these new modest pathways, they were somehow satisfying the clear congressional intent from 2008, 2009, when they amended the Controlled Substances Act and stated in the preamble commentary that they expected the DEA to create this registration. So industry went nuts. There were something like 38,000 comments that were submitted to the DEA, and they pulled the rules back. As a result, effectively, they abandoned them, and they had listening sessions in the fall with industry stakeholders to understand their concerns on this issue. And that's actually what I want to zero in on, because I think here, we don't know exactly what's going to happen, but what we do know is that in the proposed rule, they proposed these pathways for a qualified telemedicine referral. What that basically means is that a patient goes, sees a provider in person, says, "Hey, I'm interested in obtaining, I have ADHD. I need treatment that involves Adderall," or "I'm interested in gender affirming care," another type of service that requires controlled medication. "I want a physical exam from you." The way it's envisioned is you, my PCP, you provide all of the levels and the things that my psychiatrist or my provider of gender affirming care needs to know. That information is sent to them, and then I can meet with that person via telehealth so that they can prescribe the medication that I need. That was one pathway. And then the other was a three-way consultation, effectively, that you would have an in-person provider having a consultation with a prescribing provider who was at a distance, and the patient would be there in the room with the in-person provider as well, to make these services more available. And then there was the telemedicine prescription idea, which was only for Schedule 3 through 5 non-narcotic drugs, and this was really targeted at buprenorphine for treatment of substance use disorder. And what that said was that if a patient came in and needed this medication, they could be prescribed up to 30 days without the in-person exam, but that after that 30-day period, no more medication could be prescribed unless that patient were seen in person. What's relevant about them pulling back the rule, the proposed rule, and having those listening sessions is really the topics of conversation that sort of the agenda for those listening sessions mostly had to do with the treatment of Schedule 2 drugs and that's common in terms of stimulants in the behavioral health space, as well as the amount of time that would be appropriate for the telemedicine prescription for buprenorphine to be prescribed. The reason I raise that is because there's no reason to think that the DEA's thinking fundamentally changed with regard to either of the first two pathways we discussed, the qualified telemedicine referral or the three-way consult. In fact, those weren't really discussed in these listening sessions that they had with industry. So I think it's reasonable to assume that those will remain part of the final resolution, as it were. What we really don't know is whether they're going to be less. Right now, Schedule II drugs are sort of in a world of their own, and the treatment thereof is much more restrictive, and we don't know whether they're going to soften their position there at all. There has been plenty of advocacy from industry on it. We did see this month that in there's sort of an agenda that's published by the administration on a monthly basis outlining all the stuff that they intend to do. And while the DEA had said that they would have final rules that would be done by the end of calendar year 2024, again, lining up with this telehealth cliff calendar year 2024 principle, we did see in that agenda that they're expecting to release something this month, December 2023. We'll see if that happens or not. I was really scared that they were going to drop like 4:15 yesterday, the day before this presentation. Thankfully, they did not. But it's possible that we could all have some really fun holiday reading. So in terms of what's next, we're waiting on those rules, and those are the particular issues that I would be focused on when they land. DOI, Amy, back to you.
Thanks. Yes, DOI regulations, big topic that we would be remiss if we did not cover as part of this webinar. We're not going to get too far into the weeds on these, I will say, but we want to call out the background for where these came from and some key areas of note. Frankly, we're still reviewing and digesting them. I know others are as well. I know Adam's on, probably thinking he's just going to get to listen for this hour, but Adam, I'd invite you as well. If you have anything you want to add during this session at the end, please do. I know that MHA is tracking. They're gathering questions if there are questions about clarity or interpretation, because we are hoping and expecting there will be additional guidance coming out from DOI to help us make sure that we're all interpreting these regulations correctly. So by way of background, in late 2020, legislation was passed with an effective date of January 2021 that really moved the ball forward for telehealth in Massachusetts. So among other things, it introduced coverage parity for insurers, and it also included payment parity permanently for behavioral health and temporarily for chronic disease management and for primary care. It also addressed network adequacy. So it tried to strike a balance by making clear that an insurer can't meet network adequacy significantly through reliance on telehealth providers. It can't be limited to just third-party telehealth vendor types. And patients still need to be able to access in-person care if they request it. Another thing that this legislation did is also recognize care can be delivered by various modalities. So it could be a audio visual synchronous visit. It could be audio only. It could be asynchronous, but just at a very high level. So while this was a major development 2 years ago, which I also think we got just before the holidays and with some fun holiday reading, if I remember, it only goes into so much detail. So we now have new final regulations to implement, effective as of November 24th. Final regulations from the DOI, and these help to color in some of these lines. Though, as noted, we're still kind of digesting these, as others are too. They're part of a larger update to a section of the regulations, which is called Managed Care Consumer Protections and Accreditation of Carriers. So there's more going on than just telehealth in these regulations. We're going to focus mostly on the telehealth piece of it. So we can go to the next slide. Yeah, so we're not going to go through all the regulations line by line. That could be a whole separate hour. Many of them on the telehealth piece just pull and kind of parrot from the legislation substantively, but where we see a lot of action in particular is in the definitions. So we see a lot of new definitions that we did not have before. We see some expanded definitions, either expanded from the legislation or from the prior regulations. And when I look at these and I kind of pull back and say, well, what do I think the import is here? I'm really seeing expansion. The way I read it is an expanding a concept of who can provide these types of services that are reimbursable as telehealth services, the types of care, different types of modalities, and also what constitutes care. So we see some changes in these definitions to expressly acknowledge that that's not just diagnosing, it's not just treating, but it's also managing a condition. But I think, it's worth a close read of these definitions and working with the DOI to get any clarity that is needed. One particular item, which I'll call out, though, is the definition of behavioral health services. So the way that is defined now, and we did not have this definition before, it's behavioral health services that are within the scope of licensure for a healthcare professional. Now, that's not limited to specific categories for types of behavioral health clinicians, such as the ones that Jeremy was talking about, your licensed clinical social workers, your psychologists. It doesn't read in a limited way. So the way I read that is, for example, a primary care physician who is also providing behavioral health service within their scope of license that is a behavioral health service that would be reimbursed under these provisions. The other definition, which I think is worth a read, is visit. We did not have a definition of what is a visit, and now we do. And so a visit is an encounter between a patient and a healthcare professional, but it's defined to expressly say that can be an asynchronous visit. It does not have to be face-to-face. It does not even have to be audio visual. It can be something that happens asynchronously, so long as the professional is doing certain things which we would expect. They still have to, look at the patient's history, look at the condition and make a medical judgment. So there has to be some meaningful interaction there, but it's a pretty broad definition of visit. And the other thing to call out at the bottom of the definition of visit, not separately elsewhere, but it addresses telehealth visits. We do have to have consent. The healthcare professional has to be clear that this is, a visit and there can be cost sharing. And I just call that out because I would have first thought that would be somewhere else in the regs, a specific provision on consent. It's part of the definition of visit. So we can go to the next slide. Yeah. Okay, so aside from the definitions, really the heart of the new terms around telehealth are in 52.16. I have the site there for you. It's a new section called Access to Covered Services through Telehealth. While it largely tracks the statute, so I'm not going to go through, each provision of it, there are some language additions and differences, which I think are, interesting. So I put one here, which I thought was interesting. The statute, the legislation that we had, it requires that a telehealth communications platform complies with privacy rules and complies with informed consent rules. We have an additional sentence added to the regulations that carriers can't limit the use of a particular platform so long as it meets those requirements. And I read that as saying they can't impose additional requirements on the standards that the platform has to meet. There are also significant updates around provider directories for telehealth, but beyond. There's a lot more information that carriers have to track, that providers have to track to try and keep these things updated and accurate for individuals. But this also includes information on which providers are going to be available by telehealth. And generally, if you run a red line, which I did to the prior regs and these regs, you're going to see a broader emphasis on telehealth throughout. The other thing I'll note is that carriers have to submit a comprehensive telehealth plan now. And that has to include things like how our telehealth services are going to be reimbursed, what codes are required to be used to bill for these services. If a specific service is not covered when provided by telehealth, what is it and why isn't it covered? So I think there's just going to be a lot more information that we're digesting and all interpreting together, but a lot to unpack as we get used to these regs. Okay, and the last thing, which is, I think it's related, it's not 2024 or even late 2023, but worth noting is we do have a report from the Health Policy Commission on telehealth use and its recommendations issued earlier this year. This was another requirement coming out of the legislation that was effective in 2021. It is worth a read because it dovetails with some of these other topics that we've been talking about. In particular, one of the recommendations is to extend payment parity on a limited basis for primary care and chronic disease management. Now, I think that's notable because we had that on a temporary basis in the legislation, but it was not permanent the way behavioral health was. And I raised this because on our planning call, I can't take credit for this, but Adam mentioned, we want payment parity for these services, and we now have definitions from the DOI around primary care and chronic disease management. So that could be a good starting point or a baseline if there is a push for new legislation for payment parity for those services. Another recommendation that I wanted to flag, and Jeremy's going to touch on this as we wrap up, but there's a recommendation to ensure continuity of care when patients are out of state. I have a quote here that's in the report, but there's a real focus on trying to find an interstate solution so that patients who live nearby or who are out of state temporarily, that we can make sure that care is not interrupted. I'll leave it to Jeremy to provide more color on that, but certainly a topic which we are tracking. And we can go. Yes, so we're going to wrap up just quickly with some other trending topics. I mean, there's no way that we could do a presentation in this day and age on digital health innovations in the coming year without mentioning AI. We're not going to talk a lot about it. Again, this could be a whole series. MHA is doing a lot of work in this area, but we'd be remiss if we did not at least mention. We've seen exponential growth in AI, but for a long time, we've not seen overarching federal oversight specific to AI and not AI in healthcare. We've seen a lot of talk about it. We've seen a lot of movement towards it. We've seen statements issued from agencies. We've seen various orders coming out. Certainly, there are a lot of current laws that apply to AI as it would to other circumstances, but we've seen a lot more coming out in the past few months. And we expect this to change a lot in 2024. I imagine if we would be having this conversation a year from now, it would be a different conversation. I included a quote here, which I like from the HT1 final rule, which just came out, that what we're seeing is this balancing of the promises and the perils of AI, because there's a real interest in promoting this innovation and what it can do, but the perils of having bias in there, having discrimination, having lack of transparency that leads to inaccuracy. Data protection is, of course, huge. So I just listed two of the recent developments which we are tracking. There was an executive order out of the White House end of October, where the administration says it's the highest urgency to govern development and use of AI, and it calls for a coordinated government-wide approach. And out of that, HHS, among other agencies, has to do a number of things. And these are at 90 days, 180 days, and 365 days. We're going to see a lot of things coming out of HHS, which is really about a strategy to develop a plan to regulate AI in healthcare. And we have the HT1 final rule from about a week ago, very technical rule. But in short, what's interesting for us is it has an updated certification criteria for developers of health IT. So if they have a prediction decision support intervention, an AI tool effectively that meets the definition that they're providing, and they want it to be certified, they have to meet a lot of criteria, including an emphasis on transparency. How are they building the tool? How are they verifying it? What are the source attributes? They have to engage in risk analysis and management. They have to have policies in place. They have to have controls around data. How are they getting the data? How are they managing it? How are they using it? So again, this is just the tip of the iceberg of where we are headed, but certainly a very important year on this topic. And I'll turn it over to Jeremy.
The last thing that we wanted to touch on quickly, just as a quick sort of update and a reminder, is where we stand with regard to interstate licensure, which remains as important as ever in telehealth land. This map is pertaining to the Interstate Medical Licensure Compact. Physicians are not the only practitioners out there. The Interstate Medical Licensure Compact is not the only compact that is out there, but it is the one that is evolving, I guess I would say the most quickly, where there is the most opposition from state boards as well. There are certain other disciplines where it's just not controversial, and so we focus here. We've gotten to the point where I have 31 states, the District of Columbia and Guam, which are fully participating. You have another group of I guess it's 8 states. Yeah, I may have missed another group of 3 here. I'm not doing the math live. I think my account adds up to 48, not 50. But I will say we have the 31 states in DC that are participating fully. We have 8 states that are not participating and do not have legislation on the table. They're not doing anything in between. And then you've got this group in between, which is where Massachusetts lies. And so you have 5 states where implementation is currently in progress. I believe the group that is missing is that you have 3 states which are participating in that they recognize licensure applications for expedited pathway to licensure for applicants from Wyoming, Idaho, Montana, Colorado, other compact states, but they are not themselves issuing compact licenses as states of principal licensure. The way that the compact works is that you get a state from your home state, you get a license from your home state, and then you can use that to get licensed in other jurisdictions. They are recognizing licenses from other states, but those 3 states are not themselves issuing licenses that can be used across state lines. And then you have 3 states, Massachusetts being one of them, which have introduced legislation but haven't yet passed it. We were late to the game in terms of coverage of telehealth services by MassHealth, Massachusetts Medicare program. It took time for us to get just basic scope of practice regulations on the books that didn't happen until 2020. There's a trend here. We're late to the game with regard to licensure as well, but it could be worse. We could be one of the 8 states that really has done very little. But this is another item to watch, as it were. Now it is time for Q&A, and I will
just want to say thank you both so much. That was incredibly helpful, and I know you'll share the slides with us afterwards, because I know folks would like to get their hands on them, and that's one thing that's come in through the Q&A that we've already had thus far. And just I want to thank you for your framing with regards to the Division of Insurance regulations. I think it was really helpful. And just so for the edification of folks on this call, it is the intention of the Division of Insurance that we understand right now that they will probably be holding listening sessions to inform further guidance with regards to the telehealth rules coming up in the winter months here. So something to stay tuned for sure, for the additional guidance we hope to receive from the division. But a question for Amy. I loved your presentation with regards to the health-related social needs questions. And in particular, there's been a lot of excitement amongst the community health workers with regards to the reimbursement for the community health integration. My question is, do you think you'll see the adoption of those types of codes for Medicaid and the commercial payers as well?
Yeah, that is a great question. And I'll tell you that I have not been tracking Medicaid across all 50 states. I do have a couple of clients that provide these services and have been able to get reimbursement from it through payers already in other settings. So this feels to them like CMS is just coming to the table that they are already at. To the extent that payers are not covering it yet, I hope that they will follow Medicare and do the same.
Yeah, there's definitely excitement about that. And it's one of the kind of the first instances where the community health workers have been recognized for reimbursement from really any payer. And I think folks feel really, I would say very excited about that, the potential for that, that type of work. So hopefully that's something that other payers will consider covering.
Yeah, I'll say the client that I have in particular who's moved the ball a lot, it's been a discussion with the payers where they've been able to get reimbursement. Yeah.
For Jeremy, going back to the licensure regulations, I saw that there was a lawsuit that was filed yesterday against the New Jersey Board of Registration in Medicine with regards to kind of the practice of telehealth across state lines. Do you think that might have any impact in terms of moving the needle on some of these concerns that are coming up on interstate practice of telehealth?
So on the one hand, so it's a really good, it's a good question. It's an interesting question. I think it's a lot more interesting than the question of whether the suit will succeed or not, because I think states have and will maintain the power to dictate who can and cannot treat patients in their jurisdiction through the licensure through their licensure regimes. I mean, that isn't something that's going away. But as utilization patterns involving telehealth have shifted, folks tend to, whether it's a regulator or a payer or a provider, I mean, folks tend to listen to patients and patient demand. And in terms of telehealth, I mean, that has changed significantly in the past 3.5, 4 years. And I do think that there is a lack of awareness in some states as to where the state may fall on the continuum. I think that there's, it's very different to, on the one hand, take the position, which is not at all unreasonable in my view, that someone needs to generally be licensed to practice in order to treat a patient within our jurisdiction. That totally makes sense, right? Particularly from a medical board's perspective. But what the New Jersey case, which involves clinicians who provided specialty care here in Massachusetts, is really shining a spotlight on is continuity of care considerations. And whenever you talk to boards, while on the one hand, they very much do want to ensure they know who's providing care and who's treating patients in their state, they're also, and in addition to being creatures of consumer protection, that's their edict, that's their sort of charge. But they also are very, very concerned with ensuring that continuity of care considerations are addressed. And so I think in focusing on that, making clear the states, and a lot of states do have licensure exceptions, which allow providers from other states who've already treated a patient in that other state where the provider's licensed to provide follow-up care to the patient once they return to their home state. You can imagine this happens a lot with specialty care when folks need to travel from rural states to a place like Boston, where we have a ton of sophisticated academic medical centers to obtain treatment. And those rural states, by the way, are the ones which tend to already have those exceptions in place for follow-up care and that sort of thing. But a state like New Jersey, which has a lot of sophisticated institutions there in its own right, I think this suit is helpful in highlighting that, there are still plenty of states which do not have those exceptions on the books. And my view of it, just as somebody who sort of lives and breathes this space, but it's only one opinion, is that the legitimate opposition to getting rid of the licensure paradigm and allowing anybody from anywhere who has a medical degree to practice in a state should not be equated. One can feel very strongly about the importance of licensure and state-specific licensure, but still also accommodate, I think intellectually, the importance from a patient care perspective, continuity of care perspective, to allowing for that interstate practice when you've already established that relationship and are providing follow-up care for a visit that already took place.
All right, great. That's actually a really good framework. So thank you, Jeremy. Quick question, going back all the way back to kind of the beginning of our presentation, in terms of thinking about 2024 and advocacy, since MHA is an advocacy organization, where do you think our members would best spend their time and efforts in terms of advocating for permanent telehealth rules beyond the end of 2024?
Yeah, and really it's gonna change from organization to organization and individual to individual, but there's no question that the focus in 2024 is Capitol Hill, it is Washington, it is context that one has because we all have, just in our personal context, senators and members of Congress, but no, organizations that actually have strong ties to, a staffer who's in the office of a member of Congress, or on the Senate side, if there are folks for whom significant fundraising has been done and they sort of owe an organization a favor. I mean, this, to the extent that telehealth is an organization or an individual's top priority, this is the year to cash in those favors, that currency, as it were. In terms of organizations, I think MHA is excellent. And Adam, I assume my check is in the mail for that, so thank you. No, MHA does a really good job on this. I think FAH, the Federation of American Hospitals as well. I mean, they're pushing hard on this. I would also say the American Telemedicine Association, the Consumer Technology Association, its digital health branch. I mean, you're sort of seeing And this is what's kind of interesting about the fact that this still remains not a partisan issue, but it is not a foregone conclusion. And I really want to emphasize that actually, it is not a foregone conclusion that the waivers that we have seen during the pandemic are going to be extended at the end of calendar year 2024. There's a real gap between where I think Americans lie, particularly those of us up here in Massachusetts, on this health policy issue, and where lawmakers and their staff are on Capitol Hill, which is not to be hyperbolic and say that the sky is about to fall, but parts of the telehealth sky may be about to fall. So if this is what the issue that really matters the most to an organization, this is the year to be pushing on it.
Awesome. Well, thank you both. We're running up against time here right now. We want to thank Amy and Jeremy for leading a great session today. And thank you all for joining us here at MHA. My colleagues here are going to post a QR code on your screen now to see all of MHA's educational programming. We have a number of events this winter, including our annual meeting in January, and we hope to see you again soon. Most importantly, we wish you a happy holiday and a healthy holiday season. Thank you very much.